Thank you for having me. I agree with everything that Tom said. Thank you.
More time for questions?
It'll get us a lot more time near the end. So I am very happy when I listen over the last 20 and 25 years of everything and all the technology that's occurring in our industry. You see natural language processing and you go, wow, that's great. We're now using it in healthcare. Artificial intelligence, as Tom mentioned, it now could detect tumors and scans very, very early that's not even visible to the human eye. We have electronic medical records across all areas. We have 23andMe. We have machine learning even that we utilize. You have a lot of technology. And it's a great thing. I mean, even in your phone right now, you could kind of look at your heart rate. My watch could tell me everything that I need to do. But think of two things from my talk. It's going to be quick. It's going to be 10 to 15 minutes. But I want you to think of two things that we have to keep our eyes on. Let's not create data silos. Let us not create more data silos. Let's not create a retail business like an Amazon, or not an Amazon, but like a CVS Caremark or a Walgreens and these retail clinics that have their own data that doesn't come back to the doctor. And I don't know what happened. Or that you build a behavioral science organization that is very technologically oriented, but it does not share. It does not come. So the one thing that I've been pushing for the last 20 to 30 years, 20 to 30 years, I was, just about maybe 10 to 15 years old, but is to connect around the patient and connect around the providers. And I think we need both industry and we need government to do this. And I'll talk a lot about this because it's that connection and that lack of connection that it created a little bit of where we are. We are in a great place. We should be very happy, but we have to keep an eye on connections. We do not share data between payers and providers. So we'll talk a little bit about interoperability. We're going to need the government. And I'm involved a lot in that at the bipartisan group to try to push that. That's been a passion of mine for a while. So that's the first thing, okay? The second one is we're still one of the only countries on the planet that does not have a single patient identifier. I don't know if anyone knows what that is. We don't have one single record that kind of tracks us. So I'll give you a quick story. From everybody here. My mom is an elderly woman, and I'm just going to go through 1 minute. She needed something called a laminectomy and a laminotomy, which is a surgery in the back. We go to another hospital in the same system, no records. We go to the MRI place that does the electronic MRI. It's beautiful. It was great. One open MRI because she's claustrophobic. I get that. Can't send it over electronically for the surgeon to see it. They could only send the report. I have to go back over there and get it and go back and get it again. Anyway, we go to a hospital because it's a surgeon I know and it's a surgeon that's part of our community and she'll feel more comfortable. And we went and answered every single question all over again. This is a hospital within the same healthcare system, literally, who did not know that she was allergic to penicillin, who did not know that she's a diabetic, who did not know that she had mild hypertension. So everywhere we go, even within this, if I was not a physician and I did not take care of that, could you just imagine what an elderly over 80-year-old woman would be able to do in this whole ecosystem of healthcare? The lack of connectivity is it's mind-boggling. I'm sure this is a story that each and every one of you can experience wherever you go. If you leave one company to go to another company, it's kind of blind. You start over. If you leave one health plan to go to another health plan, guess what happens? We start all over again because one health plan doesn't share it with the other health plan. So all this is going to impact us and the cost and the waste and all of this. And there's a lot of studies right now in the Institute of Medicine and the National Coordination Office and even in Congress. They have, I think it passed through the House, it just has to get to the Senate, the whole single patient identifier piece. So here's some of the what is happening. And I think Tom mentioned this. It's about $3.5 trillion. We throw the number around a lot, right? That's about the fourth economy in the world. the fourth in economy in the world. I mean, when we get to 6 trillion, we will be probably larger than the economy of Germany. And yet, we're still 34th or 35th behind in quality outcomes, like any other country. So it's interesting though, when you look at that 3.5 trillion, and Tom touched upon that, you know, we spread it across everyone. You could see the Medicaid, the Medicare, the commercial, all this. Did anyone know that we had this much waste? $900 billion worth of waste. That's almost bigger than entire industries. Literally larger than industries. When you compare them to some of these industries, you could see how much bigger they are. Could you just imagine what would happen if that $900 billion was put back into research, put back into technology, put back to create a single patient identifier? For us as organizations, and many of you here as entrepreneurs, many of us are trying to gather data, and that takes up the majority of our time, is just trying to gather data. The complexity in healthcare, the lack of transparency, the lack of cost transparency, the lack of coordination, the lack of a single patient identifier, the lack of value, the lack of connection between cost, risk, and quality. I don't know if everybody knows, you see a lot of organizations out there that measure quality. HEDA stars, all these wonderful things. Then there's a lot of other organizations that look at the chronic disease management that you'll hear more and more from everyone, and they look at the stratification of that. And then there's another organization that measures the entire cost structure of all of those people. And they measure it. For a payer, they see who their high cost, patients are. And what they basically do, all of those are connected. But how could you pay appropriately in this without having access to quality? How could you pay appropriately for a 50-year-old male that's completely healthy versus an 80-year-old male that has 5 or 6 different comorbidities? They're completely disconnected even at this point in time. They're beginning to get connected. And that made it really hard for us as an organization because we're a very large organization and we touch a lot of payers and providers, and I'll tell you how we try to solve it. But that's not a point for us. It's not important that we solve it. It's important for us as an industry solve it. And there's a task group that's right now in Washington that's working on trying to get to do this. So if you look at the waste, it's interesting. You could see right up here, about $345 billion is an overtreatment failure of care, unnecessary care. Back to the example with my mom. You know how many MRIs of her back we did? 4. How many did she need? 1. Everywhere we went, we got another one. Do you know how many EKGs we did? 5. How many EKGs we need? 1. How many times we drew her blood? You got it, 10, 20, 15 times. The poor thing was like a pillow at the end of it. I mean, it was, but they everywhere and every point in her care, they could not even access the reports. That's overtreatment, overpayment, and consistently just unnecessary. Going into an emergency room. This is all in $340 billion. Going into an emergency room cold, how many people, a lot of the Medicaid population access care, primary care through what? Emergency room. How much do you think that the emergency room has retrospective data? None. So somebody goes in, says, I have a headache. How long have you had the headache? For a while. Okay. Are you seeing double? Yes, as a matter of fact, I am. Didn't matter that he had, like 5 shots of vodka before coming into there. But the point of the matter is, let's do a CT head. But a month before, they did a CT head for the same thing, for the same exact complaint, and the CT of the head was completely negative. And so it is this over-treatment and this over-repetition, but it also works in opposite. The more treatment and the more unnecessary treatment creates what? Also adverse events and mistakes, and more mistakes stay. And if you're staying in the hospital longer, you get more of a nosocomial infection, and it just keeps spinning. All can be solved with just the right information at the point of care. pricing failures here. This is basically because we do not pay the appropriate amount for the appropriate level in care. My deductibles are probably the same as my son's deductibles, who are healthy young men that that run somewhere around 10 to 15 miles per day. I can't drive 10 to 15 miles per day, but they could. Sometimes it's too much for me to just pick them up from school to come and get them. Like, do I really have to? I'm on a phone call. They're like, we'll run. Don't worry about it. By the time you get here, we'll be back home. But the point is, there's a disparity between how much I'm supposed to pay and what they're supposed to pay, and there's a disparity of how much we charge for a MRI in the hospital versus an outpatient. Really, it's just down the corner. And these things, these pricing, it just sometimes you think back and you say, how is this occurring? And I'm sorry, I'm kind of getting into the weeds, but as an executive and as a physician and also as a patient and a son of an elderly mom and have kids that have to go through multiple things, I'm interacting with it and I'm seeing the inefficiency more and more, and I could see why there's so much waste. But the concern that I continue to have and tell every single one here is, as you begin to do these wonderful technology and wonderful movement into natural language processing, and if you could figure out facial recognition that could be applied in medicine, make sure somehow that you're connecting to the right place so the patient could somehow use it. Anyway, everybody knows these next two things. So $85 billion in fraud. I don't really think of it that much. I think generally, yes, there's fraud, probably a lot. But, physicians try to do the best they can, but there is some. And there is a lot of technology that is being used right now for your credit card. Has anyone had their credit card all of a sudden get stopped or get a call? Somebody's using your credit card in Czechoslovakia, and you're like, no, I'm not there, I'm here. And so they stop, but we don't have that. We obviously don't have that, and you hear all these stories. But this administrative complexity is unbelievable. This is literally the amount of charts. So we, as an organization, we have to understand the risk of a patient, we have to understand the quality of that patient, and we have to understand how to make that payment appropriate, tied to those two. Much of that is, believe it or not, is still manual. Even electronic medical records still have a lot of manual letters that you can't read. And so all this complexity between all of the interactions between the providers and the payers and other providers and the physicians and the hospitals, all of these contractual complexities just continue to add more and more costs. $900 billion could be saved like this if we could move forward with a single patient identifier. So here's one thing. This was a study I found at the ONC. It actually looked at how the actual inefficiencies are because of you not having a single patient identifier. If you're a really big organization that has very good data and you're tracking data and you have liquidity of data, it's 7%. It could go up to 60% error rates. 60% identity error rates. Again, a mistake was someone getting heparin prior to surgery. Well, they're going to surgery. Well, it's protocol because every time you go into a medical surgical ward, that's the first thing you do. It is true. You get a heparin. But what if they are going to surgery the next day or the next morning? So it's all of these complexities that people just miss identity all the time. So here's where we've done a lot of investment in technology. We use now, you can't imagine, the pharmacies. You go to any pharmacy, you're known. Anywhere in the country. They know exactly what your allergies are. They get paid very well. They know your benefit. They know you're out of pocket. It's completely automated. 3 large companies kind of manage that system right behind it, and they're connected, and they do a lot of that. Same thing with providers. Providers over the last 10 years, as Vijay mentioned and others, the EMR adoption has worked. We were, About 5, 6 years ago, we were about 20% or 25% when Sweden was 94%. So it's working. It's doing great. Every one of these, if you go to any hospital, if you go to any facility, any nursing home, have you gone anywhere and you see them sitting there on a big piece of paper and writing? No, it's electronic. It's very good. But how much of them are sharing that data across to relevancy to the right people that need to do that? Excuse me. It's a little bit, the weather here is a little inclement for me. I'm used to, I'd rather be in 12-degree Chicago right now. It's more where my blood here is a little bit too thick. So, cost, where the care is, again, just these are important points where the patient does not know where the cost of care is, what the cost of a procedure is, where they should go. Do I need to get this procedure in an outpatient or an inpatient? They just don't. And it's just the lack of information that's coming, the transparency to that patient is really, really lacking in many ways. And they don't understand, obviously, the bills. After the surgery, I really do wish my mom never had the surgery, not because it really didn't work anyway, because we all know that a lot of back surgeries fail, but it's because right now, she's probably buzzing me right now. Hey, I just got a $10,000 bill, Emad, could you go solve it for me? And so I got this. How could an aspirin cost $150? But there's all these transparencies. So everybody's investing. Tom mentioned it. Everyone's investing, and the data analytics world, and we're investing a lot across the whole world. The majority of the investments, venture markets, private equity organizations, everyone, healthcare right now is one of the best sectors to actually invest in. When you look at telecom, when you look at financial services, communication, hotel services, all of those, over the last 10, 15 years or 20 years, they were investing 15, 20% of their revenue in technology. Healthcare was investing 1 to 3%. Now it's over 10%. So this is a wonderful time to be in healthcare. And you could see it, the investment's global. Every single place around the world is really investing. If you look at the world, and again, this further proves a little bit of my point around how we need to start to share data. You have these 3 large segments practically. You have a payer that the ultimate purpose of a payer is to manage the cost of your care from beginning to end. They have the entire cost structure of you. So they have Emad, they know everything that costs about me, they know every single utilization, they know every test that was done. Except what they don't have is the results of those tests. The results of those tests sit where? With the provider. So now they know that I did a hemoglobin A1C, but they don't know the result of the hemoglobin A1C. They don't get that. The provider gets it. They know I did an EKG, but they don't know whether the EKG is normal or abnormal. Meanwhile, you have life sciences, which are looking for patients. They're looking for patients to do research, for genomic patients, for patients that have any type, they have an inclusion and exclusion criteria. One of the hardest part, they spend about, I think, if the number's correct, somebody could correct me, it's somewhere around $20,000 to $40,000 trying to find patients. And once they get those patients, guess what they do? They measure the same things that we're measuring right now with those patients in diabetes or in chronic care or in any other type of disease. Most of all of the 3 segments, and when we look at, who knows that, I think it's all around the United States right now that ranitidine was taken off the market, right? Because of just long-term effects of that. So that's something that took about 20 years. Many of us have already taken, that for a long time. Oh, sorry?
Running out of time.
Oh, okay. So many of us, okay, I agree with Tom. Can I sit down? But many of us are doing that same thing where it's basically, we're collecting the same information over and over and over and over again, whether you're life sciences, whether any one of these. So we'll forget this one since I'm running out of time, which tells you many of those investments that are occurring right now that make me very happy is around a lot of the interoperability that's requested. This is what we wind up doing. So for us to actually execute on our model, and which is to be able to manage the payments, to manage the risk, and to manage, we had to build a longitudinal patient record. We had to build a single patient identifier. We had to do it. We had to, and let me just explain it. It doesn't cost billions. It cost maybe tens, close to hundreds, but not high hundreds. It's very easy to do. We're able to get 129 right now, 129 million, which is basically almost half of the insured market at this point. And we're going to continue to build it. And all we do, what that does, is basically it finds Emad. And every time a test comes in, we tap into the pharmacy, we tap into the payers, we tap into providers, and every time that claim or that result goes into this thing called a data lake, it finds its way because of our logic and because of our algorithms, and it finds its way to me. So now, me as an example, I have a longitudinal record that I built for myself and built for my family over the last 10 years. That I know everything and every test and every result that has occurred. Could you imagine if each one of us had that? So I built the same one for my mom now, so everywhere she goes, she actually has her entire thing on a encrypted disk. So that's what you do. Keep in mind one thing is artificial intelligence algorithms, they're only as good data in, data out. So the deeper the data, the more valuable the data, the more complete the data, the better the outcome will be. If you have we're worried about AI because we're worried about algorithmic bias. That's one of the biggest things that we're concerned about. Well, a good way to get rid of algorithmic bias is to be able to make that data very complete. So all these technologies, they'll become more powered. Everything that you actually will invest in, whether it's in a single silo or a new technology or a new app or any one of these things, make sure that the more robust that data, the more you bring data from the outside, the more that you begin to share, that any part of that application will have a greater value for your end consumer. So, thank you.
Thank you.